Question 1. A 68-year-old male with a history of heart failure is experiencing acute shortness of breath and fine crackles, rales, are heard in both lungs. His skin is pale and diaphoretic. What is the most appropriate initial intervention?
A.
Assist with the patient's prescribed albuterol inhaler.
B.
Administer 100% oxygen via a non-rebreather mask. And B.
C.
Place the patient supine and elevate the legs to improve circulation. D. Prepare for immediate cardiac defibrillation. Answer. B. Administer 100% oxygen via a non-rebreather mask. And B. This scenario tests the concept of managing congestive heart failure, CHF, and acute pulmonary edema, where the keywords shortness of breath, heart failure, and crackles, rales, indicate fluid in the lungs. Because the patient is hypoxic, lacking oxygen, and in distress due to the fluid overload, the immediate priority is to maximize oxygen saturation with high-flow oxygen via a non-rebreather mask. Placing the patient supine is absolutely incorrect, as it would worsen the fluid back up into the lungs, and an albuterol inhaler is a bronchodilator, not the primary treatment for fluid-related respiratory distress. High-flow oxygen helps combat the hypoxemia until advanced care can provide positive pressure ventilation or medications. Here's an easy way to remember it. If you hear crackles and the patient is struggling to breathe, think high-flow oxygen and position the patient sitting upright, Fowler's position, to help the fluid settle away from the lung apices. Question 2. When treating a patient with a closed midshaft femur fracture, the primary goal of applying a traction splint is to
A.
Straighten the angulation to prevent compartment syndrome.
B.
Reduce pain and minimize further injury to muscle and neurovascular structures.
C.
Immobilize the hip and knee joints completely.
D.
Convert the closed fracture into an open fracture for easier surgical access. Answer. B. Reduce pain and minimize further injury to muscle and neurovascular structures. This question tests the fundamental rationale for applying a traction splint, a key skill in musculoskeletal trauma management. The keyword traction itself is the clue, meaning a pull that counters the muscle spasms that typically occur with a femur fracture. By pulling gentle traction, the splint realigns the bone ends and relieves the severe muscle spasm, which is the primary source of pain, and prevents the jagged bone ends from causing more damage to surrounding soft tissues and nerves. Traction splints are not indicated for hip or knee injuries, and they certainly do not prevent compartment syndrome or intentionally convert the fracture to open. Remember, a traction splint's main job is to stop muscle spasms, which reduces pain and limits further internal injury. Question 3. What is the primary role of the incident commander, IC, within the incident command system, ISIS, at a large-scale motor vehicle collision?
A.
To perform patient triage and provide direct patient care.
B.
To develop and implement the strategic goals for the incident.
C.
To manage all communications between the various agencies.
D.
To record all patient care reports and incident documentation. Answer. B. To develop and implement the strategic goals for the incident. The Incident Command System, ICS, is the concept being tested here, specifically the essential function of the Incident Commander, IC. The IC holds the top management position and is responsible for setting the overall strategy and objectives for how the incident will be handled, which is crucial for managing any large-scale event successfully. While the IC oversees the entire operation, patient care, communications, and documentation are delegated to specific sections like operations, communications, and finance/administration. For example, the IC determines the objective is to safely extricate all patients, and the operations section carries it out. The incident commander is the one who makes the high-level decisions. Question 4. A 24-year-old male is found unresponsive. You attempt to insert an oropharyngeal airway, OPE, but encounter rigid resistance at the soft palate. What is the most appropriate next step?
A.
Force the OPA past the resistance with gentle pressure.
B.
Use a larger OPA to better reach the hypopharynx.
C.
Attempt to insert a nasopharyngeal airway, NPA instead.
D.
Remove the OPA and reattempt insertion using the tongue blade method. Answer: D. Remove the OPA and reattempt insertion using the tongue blade method. This question tests correct technique and troubleshooting for oropharyngeal airway, OPA insertion, and essential airway management skill. The keyword rigid resistance when inserting an OPA indicates the device is likely catching on the hard or soft palate because the airway wasn't properly opened or the tongue wasn't adequately moved out of the way. Forcing the OPA can cause significant trauma or push the tongue into the back of the throat, worsening the obstruction. When encountering resistance, removing the OPA and reinserting it using a tongue depressor to hold the tongue down is a safer and more effective technique than blindly trying another device or size. Always remember, if you meet resistance with an OPA, don't force it. Ensure the tongue is displaced forward, either with a classic 180-degree rotation or a tongue blade. Question 5. You are treating an elderly patient with signs of shock following a fall. She is on Coumadin warfarin, a blood thinner. What must the EMT be most alert for regarding this medication?
A.
Potential for a severe allergic reaction, anaphylaxis.
B.
Masking the signs of internal bleeding.
C.
Increased risk of significant and rapid internal hemorrhage.
D.
An increased risk for a stroke, cerebrovascular accident. Answer: C. Increased risk of significant and rapid internal hemorrhage. The concept tested here is the pharmacological impact of common blood-thinning medications, anticoagulants, in trauma and geriatric patients. The keyword Coumadin warfarin is a strong clue, identifying the patient as taking a potent anticoagulant which significantly impairs the body's ability to clot blood. Following trauma, especially a fall, the increased bleeding risk means even a minor internal injury can lead to rapid, massive, and life-threatening blood loss, or hemorrhage. While a stroke is a risk of the condition the patient is being treated for, the immediate trauma concern is uncontrolled bleeding. Always remember that a patient on a blood thinner may bleed out much faster internally, so maintaining a high index of suspicion for shock is critical. Question 6. A 9-year-old female is experiencing a severe asthma attack. She is conscious, speaking in single words, and has an SpO2 of 88%. The appropriate initial dose of epinephrine via autoinjector, if available and indicated by protocol, is
A.
0.5 milligrams IM in the lateral thigh.
B.
0.3 milligrams IM in the lateral thigh.
C.
0.15 milligrams IM in the lateral thigh.
D.
1 milligram for slowly over 2 minutes. Answer: C. 0.15 milligrams IM in the lateral thigh. This question covers pediatric pharmacology and dosage for epinephrine administration, often necessary for severe respiratory distress due to anaphylaxis or asthma. The keyword 9-year-old points you toward the pediatric dosage protocols, which generally dictate that a child weighing less than about 30 kilograms, 66 lbs, should receive the lower dose. The standard pediatric dose of epinephrine is 0.15 milligrams administered intramuscularly, IM, in the lateral thigh, whereas the adult dose is 0.3 milligrams. The intravenous route and 0.5 milligrams are incorrect for this scenario. Always check your protocol, but remember that 0.15 milligrams is the appropriate pediatric autoinjector dose for a child. Question 7. According to the START triage system, a patient who is able to walk when asked should be directed to a designated area and categorized as
A.
immediate, ready.
B.
Delayed, yellow.
C.
Minor, green.
D.
Deceased, black. Answer: C. Minor, green. This question tests knowledge of the critical first step in the simple triage and rapid treatment START method used in mass casualty incidents. The keyword able to walk is the fundamental principle of the initial triage assessment, immediately classifying a patient. If the patient can walk, They are generally considered the walking wounded and are categorized as minor green because their injuries, while present, are not life-threatening at that moment. This simple action quickly removes the least injured from the immediate treatment area, allowing rescuers to focus on the more critical patients. Remember the triage rule. Green can walk. Question 8. What is the most common cause of cardiac arrest in infants and children?
A.
Primary cardiac dysrhythmia, a heart rhythm problem.
B.
Sudden infant death syndrome, SIDS.
C.
Progressive respiratory failure and shock.
D.
Traumatic injury to the chest. Answer: C. Progressive respiratory failure and shock. The concept tested is the etiology cause of cardiac arrest in the pediatric population, which differs significantly from adults. The keyword infants and children is the main clue, as their smaller airways and higher metabolic rates mean they suffer cardiac arrest more commonly as the end result of a prolonged oxygen problem, such as respiratory failure, severe infection, or shock. Unlike adults, who most often suffer a primary cardiac event like ventricular fibrillation, children's hearts usually fail after a period of poor breathing or circulation. A practical example is a child with a severe asthma attack whose breathing progressively fails. Always remember, in a child, the heart typically fails due to a lack of oxygen, so focus on airway and breathing first. Question 9. When administering oral glucose to a conscious, diabetic patient with an altered mental status, the EMT must first confirm the patient's ability to
A.
Swallow and protect their own airway.
B.
State their name and current location.
C.
Accurately report their last insulin dose.
D.
Determine their current blood glucose level. Answer: A. Swallow and protect their own airway. This question tests the absolute safety prerequisite for administering any substance by the oral route, particularly in a patient with altered mental status, a key finding with hypoglycemia. The keywords conscious and altered mental status highlight the risk that even a conscious person might lose the ability to manage the contents of their mouth. Even if the patient meets the criteria for glucose administration, their ability to swallow safely and prevent aspiration into the lungs must be confirmed before administering the gel. If they cannot swallow safely, they risk choking or developing aspiration pneumonia, a life-threatening complication. Remember the safety rule. Never give anything by mouth, NPO, to a patient who cannot protect their airway. Question 10. You are treating a patient with a gunshot wound to the chest who has paradoxical chest wall motion. This finding is most indicative of what injury?
A.
A simple pneumothorax.
B.
A flail segment.
C.
A tension pneumothorax.
D.
An aortic dissection. Answer: B. A flail segment. This question tests the ability to recognize a specific sign of severe blunt chest trauma, which is the key concept. The keyword paradoxical chest wall motion is the defining sign of a flail chest, which occurs when 3 or more adjacent ribs are fractured in 2 or more places, creating a segment of the chest wall that moves independently. During breathing, the injured segment is sucked in during inspiration when the rest of the chest expands and pushed out during expiration when the rest of the chest contracts. This is the paradoxical motion. This injury significantly impairs ventilation and is a true emergency. Remember that paradoxical motion equals a flail segment. Question 11. What is the correct ventilation rate for an apneic adult patient with a pulse when using a bag valve mask? BV?
A.
10 to 12 breaths per minute, 1 breath every 5 to 6 seconds.
B.
20 to 24 breaths per minute, 1 breath every 2 to 3 seconds.
C.
6 to 8 breaths per minute, 1 breath every 5 to 10 seconds. D. 15 to 20 breaths per minute, 1 breath every 3 to 4 seconds. Answer: A. 10 to 12 breaths per minute, 1 breath every 5 to 6 seconds. This tests the current adult basic life support, BLS, standard for rescue breathing, a core skill in airway management. The keywords apneic adult and with a pulse indicate the patient needs ventilatory support but not chest compressions. The current guideline is to ventilate the adult patient 10 to 12 times per minute, which translates to one breath every 5 to 6 seconds. Ventilating too quickly, hyperventilation, is incorrect because it can cause gastric distension, lower the blood pressure, and decrease blood flow to the heart and brain. Always remember to ventilate the adult slowly and deliberately at a rate of one breath every 5 to 6 seconds. Question 12. A 35-year-old female who is 38 weeks pregnant reports a sudden onset of painless, bright red vaginal bleeding. This finding is most suggestive of
A.
ectopic pregnancy,
B.
placenta previa,
C.
abruptio placentae,
D.
uterine rupture. Answer: B. Placenta previa. This question is testing the differentiation between common obstetrical emergencies, and the keywords are 38 weeks pregnant, sudden onset, and most importantly, painless, bright red vaginal bleeding. Placenta previa occurs when the placenta partially or completely covers the cervix, and classic presentation is painless, profuse bleeding in the third trimester as the cervix begins to thin. Conversely, abruptio placentae is typically associated with abdominal pain, and an ectopic pregnancy occurs much earlier. Always remember that painless vaginal bleeding in the late third trimester points toward placenta previa. Question 13. You arrive on the scene of a motor vehicle collision where two vehicles are heavily damaged. What is the single most important consideration before approaching the vehicles?
A.
Notifying the receiving hospital about the potential patient count.
B.
Determining the mechanism of injury for all occupants.
C.
Ensuring scene safety by checking for hazards like traffic and leaking fluids.
D.
Establishing the Incident Command System, ISIS. Answer: C. Ensuring scene safety by checking for hazards like traffic and leaking fluids. The concept tested here is the absolute first priority of emergency medical operations, scene safety. The keyword single most important consideration requires the learner to prioritize their own and the team's safety above all else. Before rendering any patient care, the EMT must always check the environment for dangers like traffic, fire, down power lines, or hazardous materials. You cannot help others if you become a patient yourself. Always remember the three-part rule: personal safety, then partner safety, then patient safety, and it all starts with assessing the scene.
Question 14.
An adult patient is actively seizing. The EMT's priority of care should be to
A.
restrain the patient to prevent self-injury.
B.
Administer oral glucose immediately.
C.
Protect the patient from injury and manage the airway after the seizure.
D.
Place a bite block between the patient's teeth. Answer: C. Protect the patient from injury and manage the airway after the seizure. This question addresses the acute management of a generalized seizure, a critical neurological emergency. The keyword actively seizing directs the EMT toward immediate protective and supportive care. During a seizure, the primary danger is injury from flailing or subsequent airway compromise. Attempting to restrain the patient or placing anything in their mouth is dangerous and can cause injury. The priority is to move objects away from the patient and manage the airway, which includes placing the patient in the recovery position after the seizure stops. Remember that your job is to keep the patient safe from the environment until the seizure is over, then focus on their breathing. Question 15. The term distributive shock is best described as shock resulting from
A.
failure of the heart to pump effectively.
B.
Loss of blood volume from severe hemorrhage.
C.
Widespread vasodilation causing a relative hypovolemia.
D.
Physical obstruction of blood flow. Answer: C. Widespread vasodilation causing a relative hypovolemia. This question tests the understanding of the various categories of shock, a core concept in medical emergencies. The keyword distributive is the clue, referring to a problem with the distribution of blood flow due to an abnormal widening, vasodilation, of blood vessels. Conditions like anaphylaxis or sepsis cause the blood vessels to relax, making the vascular space too large for the normal amount of blood, a situation called relative hypovolemia. The heart and blood volume might be normal, but the pressure is too low to perfuse the tissues effectively. Failure of the heart is cardiogenic, and blood loss is hypovolemic. The takeaway is to remember that distributive shock is all about the container, the blood vessels, getting too big for the fluid inside. Question 16. In the context of documentation, what does the acronym SOAP stand for?
A.
Subjective, objective assessment, procedure.
B.
Severity, onset, associated symptoms, pertinent negatives.
C.
Signs, observations, actions, plan.
D.
Scene safety, oxygen, airway, position. Answer. A. Subjective, objective assessment, procedure. This question tests one of the essential standardized formats used by EMTs for structuring patient care reports, PCRs, which is crucial for clear and complete documentation. SOAP is a standardized method for organizing the flow of information. Subjective is what the patient tells you. Objective is what you find on exam. Assessment is your field impression, and procedure is the treatment provided. This is different from OPQRSD or sample, which are history-taking mnemonics. Using SOAP ensures that all necessary patient information and clinical actions are accounted for logically and accurately in the report. Remember that SOAP is the framework you use for writing the narrative portion of the patient care report. Question 17. The most critical assessment finding that determines whether a patient in cardiogenic shock is compensating or decompensating is
A.
the patient's blood pressure.
B.
The severity of the chest pain.
C.
The presence of crackles in the lungs.
D.
The duration of the symptoms. Answer. A. The patient's blood pressure. This question tests the critical concept of distinguishing between the stages of shock, particularly in a cardiac context. The keywords most critical assessment finding and compensating or decompensating point to the patient's perfusion status. While all signs are important, the blood pressure is the definitive, measurable sign that compensatory mechanisms like fast heart rate have failed, leading to decompensated shock and imminent collapse. A patient is compensating if the blood pressure is normal, but they are decompensating when the blood pressure drops. A practical example is a patient with a weak pulse but normal blood pressure, compensating, versus one with a weak pulse and hypotension decompensating. Remember, a dropping blood pressure is the key indicator of decompensation in any type of shock. Question 18. An EMT is applying a manual cervical spinal motion restriction to a patient involved in a bicycle accident. What is the correct position for the patient's head and neck?
A.
Flex slightly forward to maintain an open airway.
B.
Hyperextended to facilitate insertion of an advanced airway.
C.
Inline, neutral position unless movement causes pain or resistance.
D.
Rotated slightly toward the side of the most severe injury. Answer. C. Inline, neutral position unless movement causes pain or resistance. This concept covers the proper technique for manual spinal motion restriction, a core principle in trauma care. The keyword inline neutral position describes the anatomical alignment of the head directly over the torso, which is the position that naturally minimizes stress on the cervical spine. This position is maintained unless the EMT encounters pain, muscle spasm, or resistance during the attempt to align the head. Never flex or hyperextend the neck during a suspected spinal injury, as this can severely worsen a possible cord injury. Always remember to keep the head and neck in the neutral, inline position to avoid causing secondary spinal cord damage. Question 19. An EMT is assisting a patient with their prescribed nitroglycerin. Which vital sign is the absolute contraindication for administering this medication?
A.
Heart rate below 60 beats per minute.
B.
Systolic blood pressure below 100 millimeters of mercury.
C.
Respiratory rate above 24 breaths per minute.
D.
SpO2 below 94% on room air. Answer. B. Systolic blood pressure below 100 millimeters of mercury. This question tests the essential contraindications for nitroglycerin, a critical medication administered for chest pain. Nitroglycerin works by dilating blood vessels, which lowers blood pressure, and the key contraindication is a pre-existing low systolic blood pressure, typically below 100 millimeters of mercury, or often 90 millimeters of mercury, depending on the protocol. Administering the drug to a patient who is already hypotensive can cause a catastrophic drop in blood pressure and lead to shock, while a heart rate below 60 can be a relative contraindication. A low systolic blood pressure is an absolute barrier to administration due to the risk of severe hypotension. Always remember, before giving nitro, check the blood pressure because the medication can drop it quickly and dangerously. Question 20. Which of the following is the most reliable sign of adequate perfusion in an infant or child?
A.
Capillary refill time of less than 2 seconds.
B.
The presence of a palpable radial pulse.
C.
The level of consciousness and mental status.
D.
Strong, regular respirations. Answer: C. The level of consciousness and mental status. This question tests the understanding of pediatric assessment and the reliable indicators of adequate perfusion, blood flow, to the brain. While capillary refill time and palpable pulses are important clues, the patient's level of consciousness is the most reliable indicator of how well the brain is receiving oxygenated blood. The key is that the brain is very sensitive to a drop in perfusion, so any change in mental status, such as lethargy or irritability, is a significant sign of shock. For example, a child who is listless or not responding to their parents is exhibiting a major sign of poor perfusion. Always remember that a child's mental status is a more crucial sign of shock than a subtle change in capillary refill time. Question 21. After applying an AED to an unresponsive, pulseless patient, the device advises no shock advised. What is the immediate next step for the EMT?
A.
Perform a pulse check for a maximum of 10 seconds.
B.
Immediately resume chest compressions.
C.
Remove the AED pads and transport rapidly.
D.
Deliver 2 rescue breaths. Answer: B. Immediately resume chest compressions. This question tests the steps of the adult chain of survival and the proper application of an automated external defibrillator, AID protocol. The keywords no shock advised means the patient is in a non-shockable rhythm, either asystole, no electrical activity, or pulseless electrical activity, PA. According to current guidelines, immediately after the AED delivers an analysis, the EMT should resume chest compressions and ventilation for 2 minutes of CPR without a pulse check because the AED is the final authority on the electrical rhythm. For example, the patient may have a rhythm the AED cannot shock, so the immediate need is artificial circulation via compressions. Remember that after any EED analysis, immediately resume chest compressions. Question 22. Which of the following best describes the principle of implied consent?
A.
The patient is a minor and the parent or guardian is unavailable.
B.
The patient is an adult who refuses care but lacks the capacity to make a rational decision.
C.
The patient has signed a formal document authorizing treatment in advance.
D.
The patient verbally agrees to treatment with a simple yes. Answer: B. The patient is an adult who refuses care but lacks the capacity to make a rational decision. This question tests the essential medical legal concept of implied consent, which is critical for providing emergency care. The definition of implied consent is the legal assumption that an unresponsive, severely injured, or mentally incapacitated adult would want life-saving treatment if they were able to ask for it. This principle allows the EMT to provide care to a patient who is incapable of making a rational decision, such as a trauma victim in shock or a diabetic in a coma. It is distinguished from expressed, verbal consent and consent for a minor with an absent parent, which falls under a different aspect of consent law. Always remember that implied consent is used only when the patient cannot consent themselves, but clearly needs immediate care. Question 23. A patient who is alert and oriented but exhibiting slow, deep, labored breathing, Kussmaul respirations, may be experiencing
A.
an acute opioid overdose.
B.
The body's attempt to compensate for metabolic acidosis.
C.
A tension pneumothorax.
D.
An anxiety or panic attack. Answer: B. The body's attempt to compensate for metabolic acidosis. This question tests the recognition of a specific compensatory breathing pattern and its underlying cause. The keyword Kussmaul respirations is the clue. This pattern is characterized by deep, rapid, and labored breathing, typically the body's attempt to blow off excess carbon dioxide and acidity to correct a dangerous metabolic acidosis. This is most commonly seen in patients with diabetic ketoacidosis, DK, but can also be seen in other causes of metabolic acid buildup. An opioid overdose causes slow, shallow breathing, not Kussmaul's. Remember that Kussmaul respirations are the body's attempt to fix the blood's pH balance by blowing off acid in the form of carbon dioxide. Question 24. What is the anatomical landmark used to properly size a nasopharyngeal airway in PAE?
A.
From the tip of the nose to the bottom of the earlobe.
B.
From the center of the mouth to the angle of the jaw.
C.
From the corner of the mouth to the earlobe.
D.
From the tip of the ear to the suprasternal notch. Answer: A. From the tip of the nose to the bottom of the earlobe. This question tests the proper sizing technique for a nasopharyngeal airway in PAE, a foundational airway skill. Proper sizing is crucial for both NPA and OPA devices to ensure they function correctly and do not cause further airway obstruction or trauma. The standard method for sizing the NPA is to measure from the tip of the patient's nose to the bottom of their earlobe. Furthermore, the diameter should be checked against the patient's little finger. Always remember the NPA sizing landmark. Nose to earlobe. Question 25. You are transporting a patient who refused transport to the hospital after a minor fall, having signed a refusal of care form. What is the EMT's best course of action upon returning to the station?
A.
Discard the refusal form since the patient did not receive treatment.
B.
Document the refusal on a complete patient care report, PCR, and retain the signed form.
C.
Call medical direction to notify them that the refusal was executed correctly.
D.
Have a partner review and co-sign the refusal form. Answer: B. Document the refusal on a complete patient care report, PCR, and retain the signed form. This question tests the critical operational concept of documentation, specifically for patients who refuse treatment or transport. The keywords refuse transport and signed a refusal of care form emphasize the legal importance of the documentation. A complete patient care report detailing the patient's assessment, the risks of refusal, the patient's capacity, and the signed refusal form must be completed and retained by the service. This documentation is the service's only legal defense should the patient later claim negligence. Always treat a refusal of care with the same level of seriousness as a full call, ensuring full and accurate documentation is completed and filed. Question 26. When assessing a burn patient, the rule of nines is used to estimate the
A.
Depth of the burn injury degree.
B.
Severity of associated inhalation injury.
C.
Total body surface area, TBSA, affected by partial and full thickness burns.
D.
Likelihood of developing septic shock. Answer: C. Total body surface area, TBSA, affected by partial and full thickness burns. This question tests knowledge of the rule of nines, a widely used tool in trauma assessment. The rule is a standardized method for estimating the percentage of the total body surface area, TBSA, that has been affected by second-degree, partial thickness, and third-degree, full thickness, burns. This percentage is crucial for guiding fluid resuscitation in the field and for determining the need for transport to a specialty burn center. The rule does not measure the burn's depth or predict complications. Always remember that the rule of nines is a quick, adult-specific way to calculate the total percentage of burned skin area. Question 27. The most immediate life threat to be concerned about in a patient with an evisceration following a stab wound is
A.
aspiration of stomach contents,
B.
exposure of internal organs leading to infection,
C.
excessive drying and heat loss from the exposed abdominal contents,
D.
control of external bleeding and associated hypovolemic shock. Answer: D. Control of external bleeding and associated hypovolemic shock. This question tests the critical thinking required to prioritize the immediate life threats in a major trauma scenario. The keyword evisceration refers to internal organs protruding through a wound, which is a dramatic injury, but the most immediate life threat is typically the massive internal or external bleeding that accompanies a penetrating wound. Although infection and drying are risks, they are delayed threats. Managing external hemorrhage and the resulting hypovolemic shock must always be the top priority. For example, applying direct pressure to control a severe bleed takes precedence over covering the protruding organs. Remember that in trauma, bleeding is always the number one immediate threat. Question 28. Which of the following is an example of a breach of duty that could lead to a charge of negligence against an EMT?
A.
The EMT transports the patient to the closest hospital instead of the patient's requested hospital.
B.
The EMT obtains consent to treat a conscious adult patient.
C.
The EMT fails to apply high-flow oxygen to a severely hypoxic patient per protocol.
D.
The EMT accurately documents all assessment findings on the patient care report, PCR. Answer: C. The EMT fails to apply high-flow oxygen to a severely hypoxic patient per protocol. This question tests the four components required to prove negligence in a medical context, focusing on the breach of duty element. Breach of duty occurs when the EMT fails to act according to the expected standard of care, meaning they did not perform a required action or performed one incorrectly. Failure to apply a simple, life-saving intervention like high-flow oxygen to a severely hypoxic patient, as required by protocol, is a clear example of failing to meet the standard of care. The other options describe correct actions, obtaining consent, or a legal choice, transport decision. Always remember that a breach of duty is simply a failure to meet the standard of care that any prudent EMT would provide in the same situation. Question 29. You are assessing an 85-year-old male who appears confused and is running a fever of 102.5 F. His heart rate is 115 beats per minute, and his blood pressure is 105/60 mmHg. This presentation should raise immediate suspicion for
A.
simple gastroenteritis,
B.
acute myocardial infarction, AMI,
C.
sepsis, systemic infection,
D.
isolated hyperthermia. Answer: C. Sepsis, systemic infection. This question tests the recognition of early signs of sepsis, a critical, time-sensitive medical emergency that is particularly dangerous in the elderly. The keywords 85-year-old, confused, and the combination of fever and a fast heart rate, tachycardia, and borderline low blood pressure, hypotension, are classic signs of systemic inflammatory response syndrome, SIRS, which often precedes or accompanies sepsis. Sepsis is a life-threatening organ dysfunction caused by a dysregulated response to infection. While he is hypotensive, a heart attack is less likely to present primarily with a fever. Always remember that altered mental status, high fever, and fast heart rate in an elderly person is a major red flag for sepsis, and rapid transport is required. Question 30. During a primary assessment, you notice your patient's pulse oximeter reads 85%. Despite administering high-flow oxygen via NRB, the reading remains unchanged. What should the EMT first suspect as a cause?
A.
Equipment malfunction and immediately change the probe site.
B.
Massive internal hemorrhage causing blood loss.
C.
Carbon monoxide CO, poisoning.
D.
Acute stroke with central nervous system depression. Answer: C. Carbon monoxide CO, poisoning. This question tests the limitation of pulse oximetry, a vital concept in respiratory assessment. The keywords SpO2 reads 85% and remains unchanged despite high-flow oxygen are the crucial clues. In carbon monoxide, CO poisoning, the CO binds to the hemoglobin, displacing oxygen, but the pulse oximeter reads the CO-bound hemoglobin as if it were oxygenated, giving a falsely high or normal reading. However, when the patient is visibly hypoxic but the reading does not improve with oxygen, CO poisoning is a strong suspicion. Since the probe does read 85%, equipment malfunction is less likely than a blood level issue, and the best intervention is still oxygen therapy. Always remember that a patient who looks hypoxic but whose SpO2 won't improve with oxygen should be treated immediately for potential carbon monoxide poisoning. Question 31. The primary treatment for a patient experiencing a severe anaphylactic reaction with respiratory distress and hypotension is
A.
Placement in a position of comfort and administration of a bronchodilator.
B.
Intravenous fluid bolus to counteract vasodilation.
C.
Administration of epinephrine 0.3 mg or 0.15 milligrams via autoinjector intramuscularly.
D.
Immediately preparing to assist ventilations with a bag valve mask. B. Answer. C. Administration of epinephrine 0.3 mg or 0.15 milligrams via autoinjector intramuscularly. This question tests the definitive management of a severe anaphylactic reaction, a life-threatening hypersensitivity emergency. The keywords severe anaphylactic reaction, respiratory distress, and hypotension indicate a full-blown systemic reaction requiring immediate and decisive action. Epinephrine is the primary drug because it simultaneously constricts blood vessels, raising blood pressure, and dilates the bronchi, improving breathing, directly reversing the two major life threats of anaphylaxis. While a bronchodilator may help breathing, it does nothing for the blood pressure drop, making it an insufficient standalone treatment. Always remember that epinephrine is the one drug that counteracts both the airway and circulatory components of anaphylaxis. Question 32. In a patient with a suspected stroke, the goal of the Cincinnati Pre-Hospital Stroke Scale is to
A.
Quantify the severity of the neurological deficit over time.
B.
Determine which hemisphere of the brain is affected.
C.
Rapidly identify patients who are likely experiencing an acute stroke.
D.
Identify the exact cause of the altered mental status. Answer. C. Rapidly identify patients who are likely experiencing an acute stroke. This question tests the purpose of the Cincinnati Pre-Hospital Stroke Scale, CPSS, a standardized assessment tool. The keyword pre-hospital is the clue, indicating a tool designed for quick, simple use in the field. The CPSS, involving assessment of facial droop, arm drift, and speech abnormality, is specifically designed to be highly sensitive and quickly screen for the presence of a stroke so that the patient can be transported to a stroke center immediately. It is not designed to determine the precise location or severity, which are tasks for the hospital. Remember that the Cincinnati scale is all about quickly ruling in a stroke and getting the patient moving rapidly. Question 33. What is the maximum amount of time an EMT should attempt to suction the airway of an adult patient at one time?
A.
No more than 5 seconds.
B.
No more than 10 seconds.
C.
No more than 15 seconds.
D.
Until the airway is completely clear, regardless of time. Answer. C. No more than 15 seconds. This question tests a critical safety guideline in basic airway management. The concept is that suctioning removes not only foreign material but also air, which can rapidly cause the patient's oxygen levels to drop dangerously, hypoxia. The keyword maximum amount of time refers to the established limit of 15 seconds for an adult patient, 10 seconds for a child, 5 for an infant, to minimize this risk of hypoxia. If the airway is not clear after 15 seconds, the EMT must stop, reoxygenate the patient, and then attempt to suction again. Always remember the adult suction time limit is 15 seconds because you are holding their breath while clearing the airway. Question 34. An alert 25-year-old female patient with no history of trauma refuses all care and transport after a syncopal episode. The EMT should
A.
contact medical direction for advice and document all relevant information.
B.
State that the refusal is invalid due to the recent loss of consciousness.
C.
Call law enforcement to take the patient into protective custody.
D.
Advise the patient that they must allow a single set of vital signs to be taken. Answer. A. Contact medical direction for advice and document all relevant information. This question tests the essential medical legal procedure for a patient who has capacity but refuses care, which is a major area of EMT liability. The EMT's responsibility is to ensure the patient has the mental capacity to make the decision and is fully informed of the risks. Contacting medical direction is the key step to support the decision, ensuring the physician agrees the patient has capacity. After this, a detailed documentation of the assessment, risks discussed, and the patient's capacity is absolutely necessary. It is not the EMT's decision to declare the refusal invalid or call law enforcement unless the patient truly lacks capacity. Always remember that a refusal is only valid if the patient has capacity, and you must document everything and consult medical direction. Question 35. You are assessing an adult trauma patient and note a widening pulse pressure, bradycardia, and irregular respirations. This triad of signs is most specifically associated with
A.
a ruptured abdominal aortic aneurysm, AA.
B.
Decompensated hypovolemic shock.
C.
Increased intracranial pressure, ICP due to a head injury.
D.
A tension pneumothorax. Answer. C. Increased intracranial pressure, ICP due to a head injury. This question tests the recognition of a classic triad of signs indicative of a critical neurological emergency. The concept is Cushing's triad, and the three defining signs are the key clue. Cushing's triad is the body's compensatory response to severely increased intracranial pressure, ICP, and consists of hypertension, leading to a widening pulse pressure, bradycardia, a slow heart rate, and an irregular breathing pattern. This set of findings points to a severe, rapidly worsening head injury that demands immediate high-priority treatment and rapid transport. The other conditions have different, distinct presentations. Remember that the combination of slow, strong, and irregular bradycardia, hypertension, irregular breathing means the brain is being crushed.